then also at the end, if you choose to, you can aspirate and see if there's any surfactant in the end.
Leave nasal CPAP interface in place, and then lubricate the back and the sides of the supraglottic airway device.
You don't have to do that because they're extremely saliva-ish and it's extremely slippery, but it also is harmful to do it.
Attach the CO2 detector to the supraglottic airway device.
So I failed to put the Y piece on there, and so when we redo these for what you're actually going to use for the study, the Y piece will be on there.
Attach the white piece and the CO2 detector. Open the mouth and grasp the tongue with the left thumb.
There is no room. In reality, it'd be great if you could grasp the tongue and use that as your, get the tongue out of the way. There is no room. And so you kind of just do your best and you shimmy.
Insert supraglottic airway with right hand using your index finger to guide the supraglottic airway into the posterior pharynx until resistance is felt.
This is too small of a, I'm going to switch over to the appropriate size.
Are you going with the red one?
Okay, the red one looks like it's a better. Yeah. Okay. All right, so we're backing up. There is no room
Inserting
for your thumb, and so you kind of just do your best. It often does like to kind of grab the tongue, and so you kind of just, you can see it. It almost will grab the tongue and kind of pull it back, and so you kind of just guide it, and then kind of do your best to get the tongue to kind of come back up forward. Sometimes it just goes beautifully, other times you kind of have to shimmy and work it so the tongue is out of the way.
So now you're going to hold the supraglottic in place for the duration of the procedure. Additional providers will perform the remainder of the activities.
Yep.
So I'm going to attach the circuit to the
Somebody want to be my circuit attachment? So now my job, because stuff gets added, it starts getting heavy, you don't have to give a breath at all. So my job now is just so I can put this baby in a nice sniffing position. You don't even have to hold it now because now I'm carrying the weight of it and keeping it so it doesn't tilt back or forth. So my job now is essentially this. I have a chin thrust, I have them in a nice position. I'm kind of monitoring what's happening in terms of, I have kind of a visual on my depth, and I'm looking. So this baby is getting PEEP, they're getting FiO2, they would see color change. So if everything is great, great. If it's not, then we're gonna do things differently. And so if I look like I'm really, really deep, I'm gonna come back a little bit. If I look like I'm really, really far out, I'm probably just stuck on the tongue, and that's why it feels like you have resistance. And so I'm just gonna do things a little bit differently, or just kind of seat it. As Stephanie was saying, if the epiglottis gets bent down, you need to get that epiglottis out of the way. So sometimes just going a little deeper and pulling it back up. It's just a little bit of a finesse type situation. And then we have another person who would be the stethoscope looker or listener with a stethoscope. And so, like I said, the baby is spontaneously breathing. They are getting good color change. We have good heart rate, good sats. And then, if you so choose, I prefer to have the person who give a breath or two. So you're my RT at this point. And listen, and then that's it. Breath sounds. And then that person is usually at the foot of the bed. And so now their job is to give kind of comfort swaddle on the arms. And you can be done with your stethoscope.
Okay, thank you.
Now if you're done, and that goes, like our baby's still doing well. Depends on how many people you have. This person can be another person who's on my right shoulder. And then because of this, we know that we go down to the red the first time that you see red. Red means stop. So really any of those numbers are fine, or any of those sizes are fine. But red, yeah, yep. So I don't know if you guys can see this, but this is the one problem with this brand is that there's like a little rim in there, and so you have to tilt it just a little bit or twirl. You get it go down, there you go. So that is the one problem with that, is that there's an internal kind of
window right there?
Yep. And so people say, like, where in the window here does it have to be? It doesn't matter, just the first time you see red, because again, all I want it to do is to be in somewhere in that body. And so once you see red, you can just stop. And then if everything looks good, then you give it aliquot. Again, you're trying to time, but with inspiration, that's really, really hard to do. And so you just kind of do your best. Like I said, the first aliquot I usually do about 2 mLs because they're pretty dry. And like I said, you can anticipate that they might deset a little bit. And then the color change might go as you think about that surfactant is in their alveoli, so their CO2 might not be exchanging. And so once you give them they're spontaneously breathing. If they've desatted and they're coming back up, I just let them be. If on occasion they are down and down or headed down, then this is a point where you can just have somebody give a little breath or two and see what happens. And then after, you just give an aliquot, usually it's, 4 or 5 spontaneous breaths or more. And then just being patient, kind of once they're recovered, we give them about 2 or 3 more spontaneous breaths and then do another one. Depends on how big they are. If they have like an 8 ml, you might go 2 and 2 and, and start to back off in terms of aliquot size. And then if they're super small and your whole aliquot is like 2 mLs, I might do, a 0.5 or a 1 and then a 0.5 and a 0.5. So there's really no right or wrong. It's just really watching your baby and responding to what they need. After your last aliquot, we usually have like a 1 ml air chaser just to get all the surfactant. That's what you're most likely doing when you're giving ET tube surfactant also, is there's an air chaser. And then just kind of waiting, again, being patient for that baby to be really fully stably recovered. Once they are, this whole thing can just come out as a unit. You close their mouth, they are on PEEP again. And so then this baby is going to need another OG put down at some place. It's no rush whatsoever. And so if you want to put it down right away or wait, that's fine. And then you can, or if you like to know and have some feedback on aspirating the stomach to see if there's any surfactant. It's really kind of a emotional, like, hurrah if you get 0. It's kind of like you had an LP with 0 white blood cells. The reason that we've chosen not